Hello, I'm Mallie Shansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Welcome to an educational presentation and question and answer with Dr. Derek Peak. In our webinar today, we'll be discussing an advanced root canal technology that uses a combination of disinfecting procedure fluids and broad spectrum acoustic energy to effectively clean the root canal system. Before we get started, I'd like to invite viewers to use the question and answer to ask any questions, and they'll be answered at the end of the session as time permits. Now, I'm pleased to introduce our guest for today. Dr. Derek Peak is a board-certified endodontist. He currently owns and operates Eastern Iowa Endodontics PC in Cedar Rapids, Iowa. Dr. Peak graduated from the University of Oklahoma College of Dentistry and furthered his training at the Louisiana State University School of Dentistry for his endodontic residency, and also received his Endodontic Certificate and a Master of Science degree. He's an active member of the American Board of Endodontics, the American Association of Endodontics, the American Dental Association, and the Iowa Dental Association. As a staff clinician at UnityPoint Health, St. Luke's Hospital, he treats patients in the operating room as needed. Thank you so much for joining us, Dr. Peak. We now turn the webinar over to you to learn more about our topic for today.
Awesome. Thank you so much for the introduction. And I'm just happy to be here to talk about this new technology. So specifically the science and the clinical evidence behind a modern day disinfection and debridement technology. It is no secret. I am here to talk a lot about the GentleWave procedure. So I do have some speaking opportunities that I do work with Sonendo. This is just the slide that I put on there that, yes, I'm paid for by them, but these are all my experiences. These are all what I've taken from it, and they're gracious enough to let me share what I've learned and my passion for this new technology with you. So just a little overview of kind of how this presentation is going to go. First, I'll kind of give you a little bit of background of who I am. Then we kind of go into the procedure process. Then I will kind of give some supportive literature, which is also good to talk about so that you can know that this is something that is supported by research. And then I will actually go over cases. Probably the funnest part is to see these cases and actually see the difference of what the GentleWave procedure can do. So a little bit about me. Out of college, I went down to SMU in Dallas, Texas. I played football there for 2 years. Then I transferred to Wheaton College in Wheaton, Illinois. Ran football and track up there. And then after college, I decided to be a 7th grade science teacher and coach for 4 years. Dentistry was not what I thought, but then I thought again, and I got into OU dental school at OU. And so I went to OU Dental, got in-state there, right out of dentistry. I got right into LSU Endo in New Orleans. And then after I graduated LSU in New Orleans, my father, who I'll talk about here in a second, was a practicing endodontist in Iowa. And so I came back to Cedar Rapids, Iowa, and I started my practice Eastern Iowa Endodontics in 2015. But probably more important is that I kept striving and I kept learning, and I became board certified in 2017. I think that's always big to hear from anybody who actually is board certified in their specialty. And I did it about as soon as I could after I graduated endo. So learning is always something that I think is important. You always need to be making yourself better, and you always need to be learning new technologies. So a little bit more about me was I had the privilege of working with my dad for 10 years. So he just retired last July, but 10 years working with your dad, I learned so much in those years about what endo used to be, what it was when he and I were working together, and kind of what it's going to be in the future. So a little bit about him. He retired after 47 years. For those of you that are doing quick math, he actually started doing root canals when he was 24, graduated college at 20, dental school at 24, started endo at 24, and was doing root canals from the age of 24 all the way till he retired at 71. So he's done a lot of root canals in his career. And so any day we were in the office, I would always kind of go, hey, what is endo going to look like in 30 years? I mean, I know what it was when my dad first started practicing, all these little things that I noticed, but okay, I've been practicing 10 years now. What's it going to look like in another 30? And how do I extend my career? Dentistry is very tough. There's a lot of moving around. You have to work on people. You have to squeeze things. You have to hold things. You have to stand up. You have to sit down. You have to move around. Your exposure to different things. So seeing my dad's career has always kind of made me look back on my career and going, oh, I really want to be able to work as long as he did. I don't know if I can because I started later, but I need to be aware of that. I need to be aware of things that are going to make me better and make my career last a little bit longer. So a cool section that I like to go through are what I noticed as a kid when I saw my dad practice. Yes, he started without rubber gloves. But he did use a rubber dam, and he actually had film x-rays, the ones where you dip in the developer and the fixer and the rinse. And so I got to do that as a kid with my dad. There was no digital then. Working length, there were no apex locators. He did it all by hand and by x-rays. Yes, they still had bleach, and the majority of what he did was hand filing. And that's what took so long several years ago, was everything was done by hand. There was no NiTi. It was all stainless steel hand files. They used raw Theta 1 sealer. You got to mix it and get that one inch, couple millimeters above the glass slab to make sure you have the right consistency, and a bunch of cold lateral where you put a bunch of cones in there. This is a story I always like to tell, is a flame and a heat. He'd have his plugger, he'd have it back in the heat. And I'm going, what is my dad doing? He's putting something in fire, and then he's putting this red hot thing into people's mouths and searing off the gutta percha that way. And majority of the cases were done in 2 appointments until Dr. Rohn came through in Oklahoma and did some experiments and realized, all right, well, if we do everything in 1 appointment, things are going to heal just as well. And now the majority of root canals are done in 1 appointment. So you take all of what was when he started to in July when he graduated, really, there's only 2 things on that list that never changed. He always used a rubber dam, and he always used bleach. Everything else changed. So my brain has always kind of been, okay, what's going to change? What can change? What will change? And how do I adapt to this change? And it's a lot of self-reflection. It's you kind of have to look at things with open eyes and kind of realize that everything today is not going to be how it's going to be in the future. And so these past couple of years with lasers and everything, I pretty much realized that, okay, rubber dam is important. Sodium hypochlorite is important. Well, those 2 things are really important with Sonendo. And so the GentleWave Procedure and the G4 machine, like I just brought up on the screen here, is really the new way that we do root canals. And I'm going to explain how that's changed my thinking and how that thinking is allowing us to be better at root canals and allows me to be a better endodontist. But specifically, I want those of you there just to think about something for a second, is that this is primarily then and now. If I were to take us, we kind of fit in the now category, and then go back to the then category. And all you had to do is you could keep everything in the now, but you had to go back to hand filing. I would venture to say that nobody watching this ever wants to go back to hand filing. It takes forever. It's hard. You ledge. You're in there all the time. The files don't bend. They don't flex. You want to stick with rotary files. And so if you take that one step further, I think there's going to be a day whenever Sonendo and the GentleWave procedure is so prevalent that we joke or we laugh about the days where we didn't have it. I just think it's that important, and it's that much of an emphasis. And that's why we really need to talk about the GentleWave procedure and why it's so much better for teeth and for doing root canals. So that aside, really the easiest way I think to go over the GentleWave procedure is just to take 2 treatments side by side. The traditional treatment, how I used to do root canals without the GentleWave, and then the GentleWave procedure, how I perform root canals with the GentleWave. So they both pretty much start out the same. You got to take your PAs, you got to take your CBCT, you got to do your testing, you have to verify you're on the right tooth, you have to verify you trust that the general dentist got the right diagnosis. Of course, question the patient, make sure their symptoms haven't changed, make sure the diagnosis hasn't changed. So you do all that. And then the most important part, I think, of this whole thing is to make a diagnosis. And so just for a second, I'm going to stand on my soapbox. And this is one little soapbox that I will always stand on every time I give a presentation. Is the one thing I always ask is, what's the pre-op diagnosis? So those of you probably watching this know that there's a pulpal diagnosis and there's an apical diagnosis. And the really easy thing here is you just got to pick one box from the pulpal diagnosis, pick one box from the apical diagnosis. There's your endodontic diagnosis. If you need any reference, the American Association of Endodontics has its Colleagues of Excellence that goes over the endodontic diagnosis. For me, this is super important, because if I'm trying to help somebody with a case or talk about a diagnosis and I don't get one, it's kind of like me telling you, okay, we're going to go down to Cedar Rapids and we're going to run a race. And I just tell you downtown. You're going to go, where downtown? 4th and 2nd? What are the cross-sectional streets? And so for an endodontist, anytime we get the pulpal diagnosis and the apical diagnosis, we have a very good idea of where the starting line is and what led to the diagnosis and what led to the starting of the root canal, and allows us to kind of pick through the prognosis of what the tooth is going to be, and really just kind of form a better opinion and a better treatment plan of everything that goes into the tooth. So I will get off my soapbox. Pulpal and apical diagnoses are big in endo, and it helps us kind of give prognosis for the teeth. So after that, you make your diagnosis, put on the rubber dam, you get access, and you get working length. Typically that can be a 10 or a 15 with an apex locator, or you know, like what I had to do today, you put a file in there because the apex locator isn't working, and you take a PA, so take a manual working length. So pretty much both treatments start out the same. And this is kind of the first part where the GentleWave procedure and the traditional treatment can kind of take a fork in the road. So, and it comes down to instrumentation. For me, traditional treatment, what I learned. We all know this textbook. This textbook is Boss Ronnie. If anybody's going to quote Boss Ronnie, she's the one that talks about all the needle irrigations, the types of different needles, how far we have to get the needle down to the end of the tooth, and what we need to do to be able to clean out the apical portion of the tooth. So, you know, basically her textbook says get anywhere from 2 to 3 millimeters from the apex, and you really need to enlarge the root up to a 3504 or a 3006, and that's going to allow the irrigant to get all the way down to the canal. And that's how we are taught endo. That's the minimum prep size if you're going to do needle irrigation on any tooth. Still to this day, that's what I would try to do if I'm doing needle irrigation. But the thing about that is that, in my mind, takes a lot of mental gymnastics. Here's what I mean about mental gymnastics, because a picture is worth 1,000 words. This is my case. This is tooth number 14. And yes, that's how curvy the tooth is. You can't just pick up files and go, I'm going to put a 3504 or a 3006 down to the end of that, at the end of that canal. It's just not going to happen. You have to think, okay, well, my 1504 didn't go all the way. What should I do next? Okay, well, this file goes down, but it didn't quite go down all the way. So maybe I should put another file down, or that one didn't go down all the way. And well, I'm just going to do the palatal, and I'm going to instrument the distal buccal. And now I'm going to come back and work on the MB2, and I'm going to try to figure that out. Does it connect? Does it not connect? Did it go down all the way? Are the working lengths the same? Maybe I should probably take another check film. Mental gymnastics. That's a lot to think about. And that's what endo is. That's what's fun. That's what I enjoy about endo, is the mental gymnastics. But on cases like that, if you don't do it right, you can get into some problems. You can get into some ledges. You can break some instruments. And so the mental gymnastics of a traditional root canal from an endodontist perspective is pretty daunting. If you compare that to the GentleWave procedure, the minimum prep size to use the GentleWave procedure is the 2007. I actually just got off a call last Thursday. They're getting ready to change that to 1504. I think anybody can get a 1504 down to the end of any canal. And so what we're learning from the Sonendo perspective and the GentleWave perspective is that the role of the file has completely changed. The role of the file is not to instrument, not to take away dentin, not to allow us space to get our needle into the canal all the way down to the apex, but the file is there to just give us a pathway for the GentleWave procedure to do its magic, to do its refreshing of the fluids all the way through the entire root canal procedure, the entire root canal anatomy of the tooth. So that's the first big change. Is instrumentation is the big thing between traditional and GentleWave procedure. And then once you've gotten your final prep size, whether it's a 3504, 3004, 3006, or the minimum prep size with the GentleWave procedure, usually you go on to final irrigation. And with final irrigation for a traditional treatment, if you're going to do it right, you're going to go through sodium hypochlorite, you're going to rinse with saline, you're going to go through EDTA, you're going to go through saline, and then you're going to dry, and then you're going to obturate. With the GentleWave procedure, it magically does all that for you. It does the sodium hypochlorite, distilled water, EDTA, distilled water, titrates all that, and goes through all of those rinsing for you. The little asterisk there means I'm going to talk about that more in detail in just a second. But once you've gone through your final irrigation on both treatments, then, I did want to talk about this. The important thing with the final irrigation is you have to have integrity if you're not doing the GentleWave procedure. If you're doing the GentleWave procedure, you can't cheat the system. Here's what I mean. Integrity, traditional treatment, you have to have 3 different syringes measured with the 3 different solutions with the amount of milliliters that you want to go through for your final irrigation. And you have to do that. You have to put the same amount in all the canals, continually suctioning your 2 hands, your assistant's 2 hands, the whole time, start to finish. With the GentleWave procedure, with the machine, you don't. You just hook up the GentleWave to the tooth, and it does all that for you, start to finish, which I'm going to explain in a second. And it creates this little note right here that goes into my chart that says, yep, I did not cheat. These are the milliliters of solutions I put through the tooth. There are the times. That's when I started. That's when I stopped. The blue box is hiding the patient name. It has the assistant's name up there. It has my name up there. It has what type of tooth it was. Was it a retreatment? Was it initial treatment? It has all that information in there. All I have to do is start it and put it on the tooth. So a little bit more in depth in just a second, but once you do your final irrigations on both, then we all know we're going to obturate. We're going to place a permanent filling. And then if you're a general dentist working on a case, you'll go ahead and hopefully do the full coverage crown there. Or if you're an endodontist, you're going to send it back to the general dentist so they can get the full coverage crown. So back up for a second, the GentleWave procedure. When we talk about the GentleWave procedure, what is the GentleWave procedure? Basically, once we've gotten to that point where our instrumenting is done, where we feel like, yeah, I found all the canals, I instrumented to a 2007 or larger to the apexes of all teeth, I want to clean this thing out. The first thing we do is we build a platform. Again, a picture's worth 1,000 words. What we do is we have this little clear matrix right here, and then we use sound seal. And so we put all this sound seal around the tooth. Sound seal is very similar to dental dam seal when you put the rubber dam on. And so what this platform does, it makes a little hole that goes down into the system, but it creates this flat platform here that allows us to put the GentleWave procedure instrument onto the tooth. So we build a platform, We verify the access, which means we have to look inside that hole that we've made on the platform, make sure that we have a clear access to all the canals. Sometimes we have to modify that and make it just a little bit wider. Then we use the procedure instrument to run the protocol. So this is the procedure instrument. This is the new CleanFlow, which I'm going to talk about a little bit more and give some background of what the CleanFlow is. But basically, you take the CleanFlow procedure instrument, you put it on your platform, and then you put your foot on the rheostat, and it does all this for you. You simply just have to hold the procedure instrument on the tooth. It'll run 60 seconds of distilled water, do 5 minutes of sodium hypochlorite, 15 seconds of distilled water, 2 minutes of EDTA, and then 45 seconds of distilled water. Start to finish, just doing the irrigation is about 9 minutes. For me, when I put the platform on the tooth, platform takes about a minute, maybe. So 10 minutes to do this whole procedure, the GentleWave procedure. So here's the background of Sonendo and how they got to CleanFlow. So Sonendo started in 2014 with, this is called the molar PI. The most important thing of the molar PI is what's called the sound bar. So the sound bar is where the fluid comes out of the procedure instrument, hits this sound bar, and that's what causes all the multisonic energy that goes down into the canals of the tooth. And this is a great design, but Sonendo loves innovation, loves making things better. The one difficult to this is it's not super duper easy to get on second molars because of patient opening. And I think they kind of realized, hey, if we could figure out a way to not have this go inside the tooth, it'd be easier to treat every tooth. Anteriors, posteriors, second molars, way back in the mouth, minimal opening. And so they did. And in 2022, they came out with the CleanFlow technology, where basically they took the sound bar, and they put it in the handpiece. So nothing goes inside the tooth anymore in 2002. And that's kind of when this thing kind of really blew up, or I kind of realized, okay, this Sonendo thing and this CleanFlow is how we really need to be doing root canals. And so here's the CleanFlow picture of the procedure instrument. And kind of here's the comparison of the graphics. As you can kind of tell, they've upscaled their graphics too, which is really kind of cool. But I like the graphic on the right for the CleanFlow because that's kind of what my brain envisions, is that this instrument's on top of the tooth. It creates these multisonic energies that goes down in the tooth, cleans all the intricacies of the root canal anatomy, and just makes it that much cleaner all the way through. So here's the mechanism of action. How does this whole thing work? Basically, it shoots a jet of your procedure fluid across the opening, and it hits on this impingement bar on the other side, comes back across, and kind of creates vortices or kind of spinning of the fluid in the handpiece outside the tooth. And what that does, it's very similar. And then that allows it to travel all the way down in the tooth, and it allows us to get fluid out of the tooth at the same time, and then it's vacuumed out. So it's constantly putting fluid inside the tooth. It's constantly taking fluid out of the tooth, and it's constantly getting rid of all of the debris that's inside the tooth. The easiest way I know how to explain this: we've all been on an airplane. We all know what Bernoulli's principle is. When fluid is moving faster, it has less pressure. So if you think about all of this fluid that's moving outside the tooth, that allows it to pull all of the fluid outside the tooth and get new fluid inside the tooth. So if people ask, how does this suction thing work? Well, this is how it works. Bernoulli's principle. That's how it was explained to me. I've used it on hundreds of cases, and it does have a suction, which we will give it another name later on in this lecture. But the specifics of the GentleWave procedure have 5 key actions that happen while you're just holding the handpiece on the tooth. And they are super duper important for how this can work, how it can work effectively, and how it cleans out all the intricacies of the root canal anatomy. Number 1, probably, I mean, they're all important, but I think the main one is degassing of fluids, which I can't do. I can't degas fluids in my needle irrigation. No, nobody can. But what degassing of fluid does is during the degassing process, it's exactly what it sounds. It takes out all the air bubbles inside the fluid, and it allows it to be converted in the collimated jet that gives it a continuous kind of cavitation cloud in the handpiece. It also titrates the sodium hypochlorite to specifically 3%, and it titrates the EDTA to specifically 8%. Those are important numbers. I just take bleach, I pour it in the machine, and it titrates it specifically to 3%. Same with EDTA. I put EDTA in the machine, and it titrates specifically to 8%. So not only does it degas the fluids, but it makes sure all the procedure fluids are exactly the same throughout the entire process. Here's a great video to show that. On the left is degas fluids, and on the right is non-degas fluids. In a second, I'm going to click my mouse and I'm going to start both of these, and you'll kind of see how the air bubbles will go away in the degassed, but the air bubbles will not go away in the non-degas fluids. So they both should be started. So over here on the left, you will kind of see this degas fluids being put in. And in about a minute, I think that's about how long these are. Yeah, about a minute, you will see that all of these gas bubbles disappear. Most important thing that this allows us to get away from is vapor lock. We all know what vapor lock is. As you can see on the right, little bubble gets stuck, some vapor lock, and we can't clean all the intricacies of the whole tooth. And so that video is done. This video is still rolling, and you can see all the gas bubbles are completely gone. And that was just 45 seconds. So the remainder of the procedure, the other 8.5 minutes, no air bubbles inside the tooth. Gets down every nook and cranny inside of the root canal anatomy. It's specific to the fluid that you put in there, and it's titrated to the exact amount. Sodium hypochlorite, 3%, EDTA, 8%. Super important. So that's key number one. Key number two is the multisonic energy, the sound bar, which we showed the diagram before. Why is the multisonic energy so important? And what do we mean by multisonic energy? So multisonic energy is basically the continuation of those cloud bubbles that hitting on the sound bars caused down inside the tooth. And that helps all of the procedure fluids dissolve the tissue, get rid of the smear later, get rid of bacteria throughout the entire root canal system, accelerates the debridement and disinfection of basically the complex anatomy that's in the tooth. So easiest way to show this is dissolution of beef. So here's what Sonendo did. Every one of these is lean beef. Those little kind of nuggets in here, that's all lean beef, all same size, same amount in all these test tubes. And they ran this with all these different type of irrigations that we use. We use traditional needle irrigation, ultrasonic. Here's the Waterlaze, BioLaze, Edge Pro, Fontana lasers. And then, of course, over here on the right is the GentleWave Clean Flow. Now, some of these, the lasers, when you use a laser, you can't continuously replenish the fluid while you're using the laser. In this experiment, they did actually continuously replenish the fluid throughout the entire time to give them more of advantage to see if it helped them out. That's kind of what this black thing is on the side up to the test tube. They're constantly putting fluid in, they're constantly taking fluid out. We don't have that in the GentleWave one because the GentleWave does that the whole time. So I'm going to start these, and you will see that the Fontana just is kind of like a jackhammer. It's so powerful. It's just bouncing that meat around. And you can kind of see the other lasers kind of shaking things up and moving these around. But if you go back and you kind of don't take your eye off the GentleWave, is that, this is it's almost gone. It's almost kind of dissolved all of this lean beef in close to 50 seconds. If you keep watching it, it's still there, but you go back and you look at all these other ones, needle irrigation, still there, ultrasonic, still there, all these lasers. Oh, you go back, it's gone. So right about almost 50 seconds, the GentleWave system has gotten rid of all the lean beef in that test tube, and that is to the multisonic energy because of the sound bar, and it's also to the continuously replenishing of the fluids throughout the entire time you're using the procedure. So this multisonic energy is kind of a big thing for me because when I started trying this thing, I actually kind of left little things of pulp in the tooth, and I put the clean flow on there, completely gone. It's just so cool how it chews all that up. And if it can do that with the coronal pulp, imagine what it's doing way down in the apical portions, mid-root, coronal parts of the canals that you can't see. So that's the multisonic energy and why it's so important, because of the sound bar. Number 3, vortical flow. Vortical flow creates negative pressure, preventing extrusion and lifting debris and bacteria from within the dental tubules. So back when I was talking about the Bernoulli principle, this is kind of their vortical flow, which creates a negative pressure. So how'd they test that? Basically, they put the clean flow on the tooth, and it's so down here, there's an open apex, and it can make its way all the way down to the apex of the tooth without going outside the tooth. Also too, in the next slide, I will kind of show more in depth kind of the negative pressure. There's another slide, but that vortical flow is important because everything that's happening up in this headpiece, or the head of the procedure instrument, is allowing that procedure fluid to get all the way down inside the tooth, and that's creating its vortical flow all the way through the tooth. Number 4, refreshed fluids. Big deal. That's a can of Coke. That's roughly 375 milliliters. That is how much fluid goes through a tooth, and teeth are tiny. Teeth aren't very big. The canals are super small, but we can put roughly a can of sodium hypochlorite, EDTA, distilled water, combined all that stuff through the tooth in 9 minutes, which just is super cool to think about. Imagine putting a syringe on that can of Coke and sitting there and trying to syringe all that through every canal the whole time and squeezing your finger and doing that. It'd take me more than 9 minutes, I can tell you that. And I don't know that I'd be putting fresh fluid in every one of the canals every time. I might spend 1 or 2 minutes in one and 1 or 2 minutes in the other. Oh, wow, that's almost 6 minutes. And I haven't even used all of it yet. So the refreshed fluids is really important to this process. Number 5, the last one, it's going to take a second. I went too quick, is negative apical pressure. So they actually measured the pressure that the clean flow and the molar PI gets when it's put on the tooth, and it's actually it's negative. So it's a negative millimeters of mercury. To show that, so what they did, they again clean flow their tooth, open apex down into liquid, and if they run the GentleWave, well, I'll press play here, you will see it actually sucks the fluid from outside the tooth through the tooth all the way to the clean flow. Now, what's important with this is, like an example today, had a patient with an acute apical abscess, big swelling. As soon as you access the tooth, you just get all this exudate and blood and all this stuff out of the tooth. And will it ever stop? I don't know. And it just keeps coming. I hooked this clean flow up on it. I really wish I had a slide to show kind of the canister in the back of all the crap that comes out of the tooth. So negative pressure is real. It does provide negative pressure. It does suck all that stuff out of the tooth, and it also cleans the tooth at the same time, which is the best thing about this thing. It has it all. Another demonstration of apical pressure or negative apical pressure is compared to the lasers. The first click is going to show these canals are already filled with dye, blue dye. And if you start all of those, and if you look at all the lasers, The lasers can actually, even if you look at the water lays, even though you release it or you're pulling it out, it can have a positive effect on that fluid at the apex of the tooth and can cause some extrusion. When I make another click on this GentleWave system, again, it's the same setup. It's an open apex, but you can see how the GentleWave is already starting to suck some of this fluid out, and the dyed fluid is already trying to work its way down through all the canals. And once it establishes its equilibrium, all this fluid will work its way down to all the canals, clean all the canals, as you can see it there. And the GentleWave procedure is going to effectively clean everything inside the tooth and not cause anything to go outside the tooth, which speaks to its safety and speaks to its efficacy. So with that, those are the 5 key actions of the GentleWave procedure. Now, if you don't know this picture, or if you haven't seen me, or this is a picture I show every time I talk about GentleWave. Up until that moment in my career, I had to sit in that chair and I had to do a root canal. If I left, nothing was getting done. I had to be in that chair. I had to do root canals. That is my assistant, Danielle. We started the root canal procedure, or we started the GentleWave procedure. You can see kind of in the background, the screen's about halfway through. So about 4.5 minutes. I have 4.5 minutes to write a note, go call referring dentist, maybe drink a cup of coffee. Usually what I use it to is I bring up the CBCT of my next patient, or I go get the next patient numb and I get prepared for the next patient. So the GentleWave procedure has allowed me to do more in my office. And it is something that can be delegated to a dental assistant. They can pull the procedure instrument because it's suctioning the tooth and it's cleaning the tooth at the same time. Also, sometimes you don't even have to hold it because it does have that suction to it. It will suction right on the platform. And this is, I've termed this one as a ghost root canal, where I start the GentleWave procedure. It has a pretty good suction on it, and I feel like it's balanced. And I just slide the rheostat over to my assistant. This is Tessa. She just keeps her foot on the rheostat for the remainder of the procedure. And again, I walk away, I get another patient numb, I make a phone call, or I check a CBCT and get another patient numb for the next case. So this, if you've never experienced this, if you've never been able to do something without having to do something, it really just changes. We also have more pictures where, yeah, first couple of times doing this, big thumbs up. This is just cool. This is, yeah, the hose is draped over my microscope. This is before we got the G4, where it has the new arm. But they stay balanced on the tooth. So this actually 3 thumbs up, 2 for me, 1 from the patient. And this is what it looks like on the tooth. Now you can see how I built the platform here, and the procedure instrument just rests on the platform. I got my foot on the rheostat behind the patient's head, and it does its job for 9 minutes. Super easy, a lot of fun to do. So since having the GentleWave in my office, I actually have 2 different protocols. I actually do root canals 2 different ways now. And so I'm going to kind of go through those. They all start the same: PA, CBCT, diagnosis, rubber dam, access. For protocol 1 was kind of what I talked about before. I get working length, I instrument, and I use the GentleWave as a final irrigation, where it's the last thing I do. Everything's nice and clean. EDTA has been in there. It's got all the dental tubules opened up. It's ready for sealer. And then I obturate. That usually takes me about 25 to 33 minutes. The other protocol is sometimes you access a tooth and it's hyperemic. It bleeds a lot, or there's a lot of exudate. And so a lot of times what I'll do is I'll start the GentleWave, I'll build my platform, and I'll run it for 2.5 minutes. So I'll get two and a half minutes of sodium hypochlorite in there. That usually gets all the pulp tissue out. That usually gets all the exudate out. And then I can go back in there and I can verify my length because I don't have any oozing and size and all of that stuff, and finish my instrumentation. And so then I'll complete the GentleWave. I'll put the platform back on. I'll complete the GentleWave procedure. So run it the remainder 2.5 minutes of the sodium hypochlorite, 15-second rinse, 2 minutes of EDTA, 45-second rinse of distilled water, obturate, and I'm done. Sometimes those actually can go a little bit quicker, depending on the case. I really like to use and these are just my protocol 1, protocol 2, kind of what we use in my office. It's how we communicate between my assistants. And I really like to use the GentleWave protocol 2 on pedo patients, because I know those canals are going to be big. I don't really have to do any instrumentation. I just need to get all the pulp out, size everything up, then complete the GentleWave and obturate. And man, those cases, I have some to show, and they are really neat to see of what this machine can do. So we can't get by without any doing literature review. So we kind of have to talk about where we're going to get this literature. And some endos provided all this stuff. You can get all this literature from them. You can get it all from me. I have everything cited here, but the 3 big things for the literature that we want to know about the GentleWave procedure is it safe? Does it disinfect and debride the canals? And are things going to heal faster? Those are the big 3. Here they are. So safety. First one from safety is Hapasalo. And the big thing that he talked about is the negative apical pressure, is that it is safe. It's not going to shoot anything out of the end of the root. It's not a power washer. It's not going to go into the maxillary sinus. It actually creates a negative apical pressure and doesn't push anything outside the tooth. That is safe. Where we saw earlier, lasers can put irrigation outside the apex. Lasers can create a positive apical pressure. Needle irrigation, you read the Brasserani textbook, needle irrigation is a positive pressure, a positive irrigation source. So GentleWave is safe. It does create a negative apical pressure. Hapsala also talked about no extrusion, no matter what the instrumentation size. So that is great. Sometimes you have really small canals that are 1504 or 2007. Sometimes you have Powell canals that are 5006. Can you run it on a case like that? Yes, that was my acute apical abscess case today. The mesiobuccal MB1 and MB2 were I went to 2007, and then the Powell was a 5006. It was just huge. Ran it completely fine. So instrumentation size is big. The last one is also talked about no extrusion regardless of the canal size, canal type, or instrumentation size. So you read those, you look at all of those charts and you go, okay, number 1, GentleWave system, safe. Number 2, is it going to be clean? Is it going to be cleaner than some other things that are out there? Hapasalo talked about the dissolution, like that slide I showed earlier when it had the needle irrigation, ultrasonic, all the lasers, and the GentleWave is actually from their experiment. And they showed that the GentleWave system is 7 times greater at removing and dissolving tissue inside the tooth than anything else. So if you're seeing a lot of big pulp cases or there's a lot of tissue inside the tooth, GentleWave is perfect for that because it's going to get everything out of the tooth. Molina talked about the debridement, that the GentleWave system does remove 97% of all the tissue in comparison to conventional root canal instrumentation, which only kind of removes 66%. So it's going to get everything out of the canals. Wang, this is one I thought was really interesting, is that it's able to clean and disinfect non-instrumented premolars. So basically, there are little nooks and crannies I'm never going to get inside the tooth. Dentists, there's going to be something in there that I can't get a file in. There's something I can't get down. But this study showed that it's going to be able to clean that. If you can't get there, it will get there, which I think is very important, that there were no organic tissue remnants in those spots that you couldn't get a file down. Zhang, I also like this one too. And the big words on this one are anatomically independent. It doesn't matter. It doesn't matter if it's short. It doesn't matter if it's long. It doesn't matter if it's narrow. It doesn't matter if it's wide. It doesn't matter if it's 2 canals or 4 canals or 1 canal. Anatomically independent. Doesn't matter if it's curvy. Doesn't matter if it's straight. Doesn't matter if it's S-curved. Doesn't matter if it's C-shaped. Doesn't matter. Anatomically independent. You can use it on every tooth. And that's the one kind of real reason why I got interested into this is it's less things I have to put down canals or try to put down canals when the machine is going to clean it out for me. So anatomically independent, big thing. And yes, Choi, it does remove the biofilm from inside teeth. So he looked at the biofilm on the mesial roots and mandibular molars. And I have some cases that show this, that little fin that connects mesial buccal, mesial lingual, it was able to get all that tissue out of there, which is super cool. And it's actually what I've seen clinically and what I enjoy about using the GentleWave procedure on patients every day. Last, healing. Does it heal? Yes. The healing rate was observed 97.3% of cases at the 12-month follow-up. One visit procedures completed. That means like 92% of all GentleWave procedures were completed in one visit. So yes, you can use it in one visit. And yes, it is successful, which is what we want. 12-month, we're actually kind of seeing now that things are healing quicker, but 12-month is the gold standard for endo. To be board certified, you got to prove it at 12 months. I don't see them wavering anywhere of that, but I would suspect to see some data coming out that we're seeing things healing quicker than 12 months. Also, that the post-op discomfort is less. Procedure was 3.8 compared to 20%. So people who got the GentleWave didn't hurt as much. That's basically what this one says. And then the last one, that the lesions showed a sizable decrease at 12 months, which is, of course, what we all want to see when we want to see things heal. So that is the literature background. Those are all articles that you can look up. They're all cited there correctly. Majority of those are the Journal of Endodontics. And I'm sure they can be found elsewhere. So another important thing, and this is what I tell everybody, they've done over 1 million cases. 1 million. I mean, if you take 1 million and compare it to the owner of Jeff Bezos, 1 million really isn't that much. He's got trillions. So how does 1 million relate to you and me? In my career, roughly, by looking at my math, after 10 years, I'm probably only going to be able to do 40,000 cases in a career. So what's 1 million divided by 40,000? The GentleWave system procedure has already been done 25 times more than what I will ever see in my career. So that speaks to everything that we just talked about. It's safe, it debrides the canals, and we're seeing healing. And that's what we want. And that's what we want to see from new technology in endo. So this is the last portion. Let's see, how much time do I have left? Right at 46 minutes. So I'm going to make it. So that's good. So all of these cases are my cases. I got the GentleWave back in 2022. So I've had it for just over a year. And all of these cases are instrumented to a 2007 or larger. At the time, we couldn't go below 2007. I still think that's great because 2007 is easy to obturate. I'm not the best at obturating 15s or lower, but I hope to get there someday with non-instrumentation endo, because that's where this is going. So cases, tooth number 30, we kind of had to restore that mesial decay, but I didn't go above 2007. And so those are 2007. All the way down, found everything, split way down here. The good thing to compare to is, guess who else did number 31? This guy. So that's how I used to do root canals. And this is a great comparison of where endo was to where endo is going. You can easily see the difference, how there's more dentin, there's more pericervical dentin. We haven't instrumented as much. Yes, we were clean. Yes, we got the sealer all the way down to the end of the tooth. That's why I put this case first. And that's why I put this case. I am also the guy who did number 30. I like that case. It healed. It's great. Patient is happy. But when you compare it to what I was able to do on tooth number 31, I think all of us are going to go, ooh, that's just sexier. That's just, you can see the fin or the webbing in between the distal and the mesials, how it was able to clean all that. And I got sealer in there. It's a great comparison. Just where endo in my hands was to where endo in my hands is going. Again, pedo case, I talked about this earlier. I use this a lot on pedo cases, specifically because mesiobuccal, mesiolingual just join. It's kind of just one big canal. How do you clean all that? And so I tried to take several angles and I couldn't. This is just kind of like all one big canal with sealer and gutta percha all the way through to the end, and really didn't have to instrument much on this tooth. Premolar, number 5, doesn't really look like there's much canal there. So why instrument? Why make things big when you don't have to, when you can keep things small and you can minimally instrument those and get a little sealer puff out the side here and make the patient happy and make the endodontist happy. Number 3, one thing I'm going to show on this one compared to the next one, notice my access here. Not really a conservative access, primarily because we had an amalgam here and we had some decay behind it. So it carries determine the access on this one. But look at all the webbing and little kind of intricacies between MB1 and MB2. You know, the GentleWave was able to get all those little webbings in between the both of those, and it doesn't end at the anatomic apex. It ends right here off to the side. So we were able to get a little bit of sealer right off the side too, which is the beauty of this procedure or this technique. So then you compare this one, number 14. Okay, pretty conservative access. Even with a small access, the GentleWave procedure was able to clean all these canals, found MB1, MB2, distal buccal and palatal, minimally shaped those and clean those out. So a case and you can compare it to how endo again used to be. I didn't do this one. If I did, I would take ownership, but that is not my obturation on number 13. Again, the beauty of the GentleWave procedure. I'm looking at this going, oh, buckets. How am I going to get a 3006 or 3504 around this curve? Am I going to leave an instrument there? And what's going on here? Or if you run the GentleWave and you don't have to instrument, you can take smaller canals around this S curve at the apex, and you're going to know that the GentleWave is going to clean out this little lateral canal on the mid root. 2 sealer puffs, great case, patient's happy. More importantly, endodontist and dentist is happy. We didn't leave anything behind on this case. Another big caries, and this one you can kind of see how do you instrument this delta on the mesial root? How does that happen? Or this little canal that goes sideways or one that goes straight? You know, it's just you don't know what you're going to get with the GentleWave procedure because it just is going to clean everything, and you get these little fireworks at the end that go, man, I'm glad I have this in my office. And long roots, super long roots. Is it going to do that? Yep. It's going to get all the way down there. Again, didn't really have to instrument much. Again, minimally instrumented on these because they are already big enough. I just wanted to make sure that we got clean all the way down to the apex, and they did. If you're going to understand difficulty of endo, if you draw a straight line from the orifice to the apex and the root goes outside that straight line, it's a severe case. It's an extreme case. So also means it's a difficult case. So a little tidbit there. A case that was started by referral, another pedo patient. You know, again, I took these different angles and really couldn't quite see where everything went. So took a CBCT, and you tell me how you're going to instrument all those little nooks and crannies on that mesial root. Are you going to put a bunch of dentin debris in those and not be able to clean them out? But the GentleWave just does all that. I can show my anterior cases now because CleanFlow is FDA approved for anterior teeth, all teeth. And those of you that are astute, maybe you might see a radiolateral radiolucency here. And when we run the GentleWave, it was able to clean that lateral canal. Got these little deltas at the end of number 8. Again, super cool to be able to see doing endo. Yeah. How are you going to clean that? How are you going to clean this internal resorption of maxillary central? Big lesion. You know, normally we would clean that and put calcium hydroxide in there, let it sit. And then really, how are you going to get all the calcium hydroxide out? And then you're going to obturate it, where with CleanFlow, again, huge, very little dentin on there. big internal resorption. Ran the GentleWave, cleaned everything out. And this patient's doing great. So one appointment, internal resorption, awesome case. This is another case I kind of call my back to the future case, is that I was never patent in this distal canal. I got to about right here. You know, mesials are 18, 19, distals about 16. I go, well, good news is I got the GentleWave procedure in my office and I ran the GentleWave. No way am I ever going to get a file to go back and forth on that and get down to the end of that apex on the distal root of number 30. So that's why it's just an invaluable tool to clean everything inside the tooth. So I do have some cases that I've shown some healing on. I got about 5 minutes left. So I ended up doing this root canal on number 4 or on number 5. Patient came back with a lesion on number 5, but we need to read this x-ray. What's also not here? Number 4 is gone. So at some point, this tooth was taken out. We made a new 4-span bridge. Maybe my endo didn't fail because of my endo. Maybe it failed during the process of making this new crowns, or, you know, getting some saliva in there during the try-on process, whatever. Anyway, we can't do the surgery on this because of Auntie's law. As soon as we do the surgery on this tooth doesn't become a very good anchor. So really our only option is to do a root canal. Well, or redo the root canal. Well, I don't want to make this any bigger. So all I did was take the gutta percha out and redo it. So here's a lesion. It's there. My original root canal looks great. Nothing short, nothing long. So I simply just took the gutta percha out, ran the GentleWave, and put new sizes of gutta percha back in. And in 4 months, lesion is pretty much almost gone. I think it was, you know, got this little fin in there too, which is nice to see. But what does the CBCT say? There's pre-op, there's 4 months. Already can kind of see the bone filling in here, bone filling here, patient asymptomatic. Good case. This is very similar to the first case I showed, minimally invasive. 2007, sealer puffs down at the end of the tooth. You know, still kind of questioning, is this big enough because of what I learned with Basrani? Yes, 5 months, lesions are gone. What's the CBCT say? Definite lesions, pre-op, 5 month, definite not lesions, 5 month. So we can instrument smaller. It is going to heal. We are disinfecting. It's safe and it's going to heal. That's what all these cases should be portraying. This is another one. Unfortunately, the general dentist thought they could do this and got a headstrom stuck in there. Pretty much no way I'm getting that headstrom out of that mesiolingual root. I offered the patients, hey, we can try to see if we can clean around it. I don't think anything's coming out, but I certainly didn't want to tell this young man, hey, you know, as a teenager, we need to pull your tooth. So we ran the GentleWave, got a pretty good sealer puff. That was on purpose. I tried to see if I could squirt some sealer down around this file after I did the GentleWave procedure, which I'm pretty sure I did. In 3 months, lesion has showed significant healing and patient is asymptomatic. What's the CBCT show? Definite lesion, definite healing of the lesion at 3 months. Patient's happy, parents are happy, which is probably more important. This is my last case. This was a case done by a endodontist in my area. Good looking case. Everything's filled. Patient came back with a lesion on the mesiobuccal root, and unfortunately, the patient was told that they needed to have the tooth removed. Thankfully, they found me for a second opinion, and I said, well, I think we should just redo the root canal, see if this heals. So here's the lesion, pre-op, loss of cortical bone, can't really make out the maxillary sinus, no furcation bone, all canals found, so good endo. And so we decided to do the GentleWave procedure on this. Took everything out, filled everything back up. Sealer puffs, not necessarily my intent, but they happened. And so there's post-op. We had the patient back at 3 months, huge healing, lots of cortical bone there. Patient did get the crown. Let's look at the CBCT again. Here's pre-op. Here's 3 months. Look at all this cortical bone back, all of this furcation bone, all this bone here, just at 3 months. And to top that off, not only do we have a 3-month, but we also have a 6-month. And the comparison is even better. You take the 3-month and give it 3 more months. Now look how smooth this maxillary sinus is. Look how smooth this nasal mucosa is. Look how dense this spongy bone is getting in between the roots. And the best thing is to compare it from 6 months ago. The fact that just redoing this root canal, running the GentleWave, getting all this bone back, patients happy, parents happy, no more symptoms in just 6 months. To me, that's why I have this machine. That's why I use the GentleWave procedure, because for me, every time I treat with this machine, it's believing. I'm seeing all these results. I'm seeing these happy patients. I'm seeing these lesions healed, and it's just making endo that much better for the patient and for the profession. So with that, I'd like to say thank you. This is my wife, Amanda. She gracefully let me stay late tonight. These are our 2 puppies. This is Zoe here, and this is Kona. They are my office assistants. That is them working hard in my office on a daily basis as we treat patients. And I just took the Sonendo little logo and put it on my logo here. I use it just not for marketing. I just use it whenever I get presentations, that just to show that I'm attached to this technology. It's made me better. It's an integral part of Eastern Iowa Endodontics. And thank you very much for letting me share my passion and share the GentleWave procedure with you. I hope you learned a lot. If you have questions, please find me on the internet. Please call me. Please email me. I'd be happy to help you in any way I can. So thank you.
Thank you, Dr. B. Very good presentation. There are some questions coming in.
Okay.
But before I get to those, I'd like to invite viewers to use the question and answer feature in your control panel to ask any questions that you have. First question: How do you and your staff get trained on the GentleWave?
Basically, Sonendo comes out and they train us. So when they train me on how to use the machine, they also are training the assistants on how to do the maintenance and hold everything and to get everything set up. So the company does a great job. I can't say enough about my rep, Tammy. She was fantastic. My assistants love her. So they know how to uptake it, or they know how to keep it working. And they also show me how to use it on every tooth and how to do the platform and all that stuff. So Sonendo takes care of all that for you.
Okay. Will the GentleWave procedure slow me down?
No, the GentleWave procedure hasn't slowed me down, because you got to think you've gained 9 minutes on every one of your treatments. So it's not you sitting at the chair. The treatment may be longer, but you get a break of 9 minutes in the middle to go do a consult, or to go make a phone call, or to go help the front desk, or to go read a CBCT, or to go prep the next patient. So it's actually giving you time. It's actually giving you 9 minutes to be more productive throughout the day. So, I mean, just round it to 10. If it were to 10 minutes in 6 patients, you've gained an hour throughout your day. So I'm finding more and more that it's actually making me more efficient than actually slowing me down.
Okay, thank you. Could you review some more about negative apical pressure?
Yeah, the negative apical pressure is just basically whenever the fluid moves across the procedure instrument in the mechanism of action in the procedure instrument, and all the circling of the fluid when it goes on the impingement plates, all that circling does create a lower pressure, and that's what allows the fluid to be removed from the tooth. It also is able to put fluid in, but remove fluid at the same time. A pretty cool mechanism of action, all because of the movement of the fluid and the negative apical pressure.
Okay. Do you charge for the GentleWave? How do you make this a profitable procedure?
Yes, I think every endodontist you ask is going to say yes, they charge for the GentleWave. The procedure instruments do have a cost. They are not free. They are single use. And so to help me, basically what I did is whenever I started incorporating the GentleWave, I didn't want it to be like an a la carte. Like, I didn't want all the patients to see, well, you're just nickel and diming me. You're putting all these things on my bill, and why am I paying, and why? So when I started a year ago, I just raised my fee and just incorporated it into my root canal fee. So there were less line items. and that seemed to make things easier. That's definitely one way to do it. You can itemize it out and use another code if you want to, but yes, I do charge. It is part of the procedure fee whenever I do a root canal.
Next question, is there a consensus on the efficacy of the GentleWave system?
I think the efficacy kind of goes back to that slide where I talked about the million cases. I mean, they've done 25 times more than what I'm ever going to do in my career. Like if I started now and I did root canals with the GentleWave, I mean, I am doing them now with Sun Endo the rest of my career. It's not even going to be, it's going to be less than that because I've already been practicing for 10 years. So I think that really speaks to the efficacy. And actually, 1 in 5 endodontists right now have a machine. So, that's not a lot of the endodontic population, but more and more every day are buying the GentleWave procedure, and it's being incorporated into endodontic residencies. So a lot of residencies have the GentleWave procedure. So as residents are coming out, more and more future endodontists are going to have it. And specifically, one was just put in down at LSU, so my alma mater. Go Tigers. They got a GentleWave unit. And so they're going to start learning the technique down there. So that I think speaks to the efficacy of this technique and how it helps endodontists and dentists do a more minimally invasive, less invasive root canal procedure.
How can you review a little more about how it compares with lasers?
Yeah, so lasers, lasers you use in a wet canal, you have to put the laser in the tooth. You have to remove the laser slowly out of every canal, and you can't really replenish the fluid as much. So with lasers, you have to be present. You have to be in the chair. You have to activate it. You have to activate it in every canal. You have to do it in every canal multiple times, and it requires you and your assistant. I think that's the big comparison to the GentleWave procedure is I don't have to be present, number one. Number two, the machine replenishes all the fluids for me, does all the math, does all the titration, does all that stuff, suctions everything out for me, collects everything into a canister, and I can go do something else. So lasers are very much hands-on. Also the big thing of GentleWave is the degassing. I think that is, even if you're using lasers, that fluid's not degassed. For the GentleWave, it is degassed. And just the multisonic energy, it just chews up all the tissue, sucks everything out, and gets rid of the biofilm all at the same time. So it's in my brain, again, I'm trying not to poo-poo lasers. They all have their protocols and their indications of use. But for doing minimally invasive root canals, putting less things down the canal and cleaning canals, the GentleWave is what I see as the future.
Okay. Are there any cases in which you cannot run the GentleWave procedure?
Yes, it's not advocated for primary dentition, and it's not advocated for third molars. Pretty much everything else. The majority of Americans have numbers 2 through 31. We have our second molars and first molars, all our anteriors. So pretty much every tooth in a normal adult, minus the third molar, you can use it on every one of them. And I've done it on all of them. So I can say I've done it on every tooth, and it is now indicated that you can, which is good.
Yeah. And the last question, how do you explain the GentleWave procedure to the patients?
That's a good question. We really we've kind of been more going to, it's kind of like a tooth jacuzzi, just because, one, it's a fancy machine. It's like a machine that you would see at a spa. And so spa and jacuzzi, or sometimes you'd say it's the tooth spa. I'm trying to get away from a power washer. Power washer is kind of like a power washer, and it's not that. It's not shooting something down the tooth. It's actually using the multisonic energy to work its way down the tooth, massage all the walls and clean all of the walls, and really kind of use those small cavitation bubbles to kind of jacuzzi everything out of the tooth. And patients seem to go, man, that's awesome. Man, that's really cool. And they seem to really love it. And we are seeing a decreased amount of post-op pain when we use the GentleWave. And I just can't get over how clean the inside of the tooth is every time I take that procedure instrument off a tooth. I've done, hundreds of cases already, and I still think it's great. I still think it's super cool to see, and patients love it, and teeth love it even more, which is really good.
Thank you. Thank you for your everybody for your questions, and thank you for your webinar, but we've run out of time today. If we did not get to your question, we will answer it after the webinar via email. Within 1 hour, all registrants will be emailed a link to the replay and continuing education quiz to complete for the certificate. Thank you all again for attending, and a special thank you to Dr. Derek Peak and our sponsor for the webinar, the GentleWave Procedure. Thank you all, and be well.